Virginia the waters. I did not
Pete
go
Bowles, how
carry
you doing?
anything.
We'll be here at noon.
Okay. Okay, everybody, here we have the agenda for the City Council work session here on Thursday, February 23rd, 2023, at 11:30 a.m. in the City Hall Council chambers. We are doing a City Council work session today. Angie, would you do a roll call, please? Or excuse me, calling the meeting to order. Angie, would you do a roll call, please?
Nestle,
Here.
Tryon. Here. Bowles.
Here.
Lucas.
Here.
Garrett. Flanders. Reeker. Woods.
Thank you. Open Meetings Act. Current copy of the Open Meetings Act of the State of Nebraska is posted on the wall at the back of the council chambers. No formal vote or action will be taken at this meeting. I repeat, no formal vote or action will be taken at this meeting. This is purely informational. And we'll have a presentation by Spencer Thomas, Apta Health, on renewal of the city's health insurance. We will also have some lunch delivered about noon for us to eat, just so everybody knows. Okay. That being said, Lane, do you have anything to warm this up, or
Sure.
turn your mic on?
There we go.
Okay.
All right. In the past, as most of you know, we've had a work session right before a regular council meeting to approve our renewal for insurance. And we thought, it always seemed rushed. And so that we wanted to have this work session today where we weren't under a time constraint, number one, and number two, then gives you a couple weeks to digest the information and really kind of dive into it a little more than we've sometimes been able to with a time constraint. So that's really the reason we're here today, is to do what we've done in the past, but with less restrictions on our time.
Thank you. So as we always do during work sessions, it's far less formal than a meeting, so you don't need to request the floor. Just ask your question and try not to step on top of each other's toes. Okay. That being said, Spencer, you have the floor.
Really quick, I know we're going to hit kind of a couple of items today. We'll hit the medical insurance and the medical renewal, but as part of that, one of the big changes that we have observed this year that we wanted to recommend was some changes to the ancillary, particularly concerning the vision program that will have some impacts kind of on a couple of different departments. So if I may, just for the beginning of this, I'm going to turn some time over to my colleague, Jan Mock, in our office to kind of talk about some recommendations to the vision coverage, and then we'll go from there.
Thank you. I won't take up as much time as I did during the first meeting. I just wanted to go through, I'm not sure how often
Jan,
you really look at this.
would you hold off and wait till you're in front of the microphone, please? That's all right. Thank you.
I have such a loud mouth, I did that the first time anybody asked me that, thank you. Okay, I wanted to go through, I'm not sure, I don't think a lot of people think about what benefits you actually offer, so I want to spend about 5 minutes. I put together this summary for you to explain these great benefits that your employees are getting, and we're going to try to get those promoted a lot more so that they understand what the city's actually providing. As you're probably aware, you have a $40,000 base life insurance benefit that the city pays for, and we increased that from $30,000 back in 2012. You also give the spouse and children of their employees get a base benefit. The AD&D benefits, a lot of people aren't aware how rich they are. In addition to covering collegiate benefits, loss of use benefits, which you didn't have covered before we moved you over to this carrier. You've got occupational assault. Your employees get an additional benefit for that. A line of duty we added for the police department and fire department. So if somebody is killed or hurt in the line of duty, they get an additional benefit. So as an example, if you have someone that, let's say they die versus going through all the dismemberment benefits, due to an accident, their beneficiary would get the $40,000. If it's due to an accident, they get another $40,000. If it was on a common carrier, on a bus, a plane, they get another $40,000. And if they were in the line of duty, they get another $40,000. So actually, they get a $160,000 benefit, which is great. I think people need to be aware of it. You guys did a great job of getting these benefits out there. They also have, if an employee dies, they have additional education for the spouse so they can go back to work. They pay an additional benefit for higher education for any children left behind. if someone is hurt, can't get back to work, they pay them up to $10,000 to help rehabilitate them to get back to work. You have a travel assistance program. You also, which we hope employees are taking care of, you provide free will preparation, which is the same as paying an attorney $500 to get a will. Free will preparation, so there's no reason why your employees and their spouses should not have a will in place. They assist with funeral arrangements, grief support for the spouse and family, actually in-person visits. So your life benefit isn't just, oh, we've got life insurance. It goes above and beyond that.
Jan, if I could real quick, the council is also covered by that life insurance policy, so that free will preparation stuff, that is something, and as you
Yes,
mentioned
thank
earlier,
you.
you can do the will preparation now, and in 10 years, if you're not on the council anymore, you still have that will available
Yes.
to you. So just as a little added aside that we learned today.
Thank you. Yeah, the one with Standard, I did my will through them 14 years ago, and I just last year went back in, even though we're not insured with Standard anymore at our company, and I went back and updated it. Just to give you a little bit of history, we changed to the Standard in 2010. We added a lot of these different enhancements, but we were able to reduce your life rate by 37% in doing that and offering these additional benefits. You had a very small increase in 2013, but the rates are still lower. They increased the life rates in 2017. I went out to market. I went to 8 different carriers, and not one of them could compete with your rates with Standard back then, and that they couldn't compete with them even taking off a lot of these extra benefits, like the line of duty benefit. You pay 2 cents per, you pay 2 cents per $1,000 of benefit for that. But even removing all those, they could not compete with your rates. You have not had a rate increase since. Your rates are guaranteed till 2025. Of course, we know your population is getting older and you have more males per capita. So right now, there is no reason to really go out and look at anything else, because we know that in 2017, you were very competitive, and you still have those same rates. You do offer voluntary life to your employees. On the city paid and the voluntary, on the dependent life, if an employee dies, those benefits are continued for those dependents for 5 months after death at no cost. So that's always a plus, that people that are left don't have to worry about things like that for a while. The dental, we moved to principal in 2017. It's a standard dental plan. Preventive diagnostics covered 100%. There's no deductible. And what we did in 2017 when we moved to principal, there is no annual maximum on the preventive or the diagnostic. So where a lot of employers now are increasing their $1,000 benefit to say $1,500, which increases the premium. Instead, what we did is we said we're going to leave it at $1,000, but we're not including the maximum on preventive and diagnostic. So that basically gets you up to that point. You used to be, prior to then, you were always, they always look at your claims experience, and you are, I shouldn't say you, the city of North Platte is high utilizers when it comes to dental, high claims. So your claims kept going up, and your premiums kept going up every single year. So one of the reasons we moved to principal will not look at your experience. You are pooled with other groups in Nebraska, municipalities, and that's why the rates have stayed down as much as they have. You have had some increases, but if we look back at what your rates would have been if you would have stayed with MetLife in 2017, your average change in rates has been minus 0.2614% per year. And when you look at trend currently at 4 to 4.5%, I don't know of anybody out there that could say that. In other words, I'm looking at average increases of between 4 and 5% a year. And if you go to experience rated, which is what most carriers will do with you, it's going to be more than that. So you have come out very, very well, in my opinion, going to the principal. In fact, even Brenda mentioned it earlier, even though I'm sure everybody's aware that North Platte it's very difficult to get providers to join networks. Your network for principal has even more available than Delta Dental does in the state of Nebraska. So having your 8 providers that are in network is probably about the best you're gonna find.
I would add too, Jan, for the council, so the employees in most of our departments pay 100% for their dental. That's a benefit they choose. It's only fire and police that, through their contract negotiations, have had some dental benefit partially paid for by the city, but the employees pay, for most of the city departments, the employees pay 100% of their dental if they choose to have it. So that's not a city cost for most of them.
Lane, I don't mean to interrupt the presentation, but what are you hearing? Are you hearing from the employees that the access to in-network providers is sufficient on the dental?
Yeah, I have not had any complaints on the dental from the employees. I mean, I think everybody knows that dental's not great anywhere you go. I mean, it is what it is. So we don't have people complaining about it.
And the one thing we were able to do when we moved to principal is if they go to an out-of-network, yes, they're gonna have to probably, unless they have a deal with their dentist, which you can do if you ask in advance, but 99th percentile. Typically, the highest you can see a carrier go is the 95th, and what that means is 99 out of 100 dentists in this region will accept their reimbursement. So typically, the highest you can get is 95th percentile. We were able to get the principal at the 99th. So even if they are seeing somebody out of network, they're not going to have to worry about this huge out-of-pocket cost, since the majority of their claim, if not all, should be covered for reimbursement. Vision, you are currently self-funded. You've been self-funded forever, and you're self-funded through Meritain. We've been having claims issues as of late with getting claims adjudicated because they tend to fall under go through the medical first. They're just very time consuming. So Lane and I decided to look, and actually the city looked at this about 7 years ago, but decided just to stay put. We looked at going fully insured with, after looking at several carriers, with VSP, and we talked to the employee committee about it this morning, who have agreed to make the change. Currently, your benefit is everybody gets $350 a year, and that includes, I mean, whatever that will buy them. So an exam, their lenses, their frames, there's a lot of, any enhancements. $350 doesn't really go that far as you get older and when you look at your older population, because most people don't wear just plain lenses anymore. As we get older, we tend to go to transitional bifocals, things of that nature, need custom types, which under your current plan, I talked to a few people today that said, yeah, it usually costs them about $400 out of pocket when they get glasses, when they get their bifocals currently with the $350. It doesn't cover non-prescription glasses or sunglasses. So your employees now don't really see the vision as really that great of a benefit if they don't have any eye issues other than getting their eye exam. With VSP, they will be able to choose every year if they want non-prescription glasses, because say you don't wear glasses. They're going to have co-pays. The benefit is going to be quite a bit better. I think we had a great reception at the first meeting.
And I would say this is actually less cost to the city than our current plan by going with the VSP. It's a few $100s a month less than what we've been averaging on the eyeglass claims by going to the VSP. And there's not going to be ups and downs that we see now because it's just your flat monthly rate. And so it's actually a cost savings for the city, and it is a better benefit in our opinion to the employees.
And no budgeting.
And that's what I was actually pushing Jan on, I was looking for ways to save money, and so when we could save some money and actually increase the benefit, I thought it made a lot of sense.
Oh, definitely. And we're also going to add a buy-up plan. While the plan is has a lot of enhancements, we're going to have an option where if employees, at their discretion, say they want lineless, custom bifocals or trifocals or what have you, and they want the no scratch and all of that, all of those included at 100%. So they can buy up to a very rich plan, paying that difference in cost. And there were a lot of people excited about that because I know they use those.
The employees would cover that difference.
Right, they'd pay the difference. The last thing that we discussed is you have employees that are required in their job to wear safety glasses. Now, it's great for those that don't wear regular glasses, that don't need a prescription, because they can go to Walmart, wherever, and for $10, whatever, buy those. But for those with prescriptions, for what I understand, currently, every department has their own different way of handling it, and how they're gonna reimburse, and how much money, they're gonna reimburse employees, which of course also means the employees have to pay out of pocket for their safety glasses that are required, and wait for reimbursement for that. So, through VSP, they have a company called ProTech that has safety lenses that meet all the ANSI requirements, safety frames that have the side guards, all that. And we have found a vendor in town that will put up the full display of all the frames and lenses available. And that way we can add that. In the early meeting, they decided that made sense too, to add that on. We can add that on to VSP. It will only be for employees that are required to wear safety glasses in their line of work. And the cost is $1.59 per employee per month. And I can't picture anybody getting a pair currently of going somewhere and getting prescription safety glasses and frames and side guards for $1.59 a month. The employee doesn't have a copay. They're paid in full. Unless they want enhancements, then they would pay the difference for those enhancements. So this way we can make it equal for every single department within the city, that this is what you're going to do going forward. Not everybody's going to have their own, well, we're going to give them $350. Well, we're going to give them whatever. And it's a great benefit for people that have to wear glasses and are required to wear them for work.
Thanks, Jan.
You're welcome.
Anybody have any questions on?
Yeah, Jan, a quick
Yeah,
question
hold
for
on.
you. Do you see the city's dental plan, do you see it as standard for municipality, less than average, greater than average, or what's your assessment of that
With
particular
all
insurance coverage?
with all the municipalities I work with, and I work with a lot of
Yeah.
them, I'd say you are standard.
Okay.
What I'm seeing this past year, because of course with inflation, is the annual benefit going up. $1,000 10 years ago was a great benefit. $1,000 now doesn't cover quite as much. So I see more plans at the minimum for municipalities going up at least to $1,250, some to $1,500. But the plus you have going on is that we took out the preventive and diagnostic towards going for that $1,000. So that gets you more in the, say, $1,300 line.
Okay, that's, the thousand's the reason I asked the question, so thanks, that answers
Yeah,
it.
that 1,000 looks low, but that's where you have to point out the fact to people that say something that, but preventive and diagnostic isn't included in
Right,
that.
and then it encourages it under the structure too, right?
You
Yeah.
got it, exactly.
Okay, thank you.
You're welcome.
Yes, I have a question. I don't know that much about insurance, but so this is everything but medical, right?
Yes.
Is that what I'm understanding? Okay.
This is
thank
your
you.
benefit, except medical, except that I know you have benefits that you offer through AFLAC, and I have nothing to do with those.
And that's all employee paid throughout.
That's all employee paid.
Thank you. That's what I thought this was. but-
Any other questions? I know how much more exciting medical is than the ancillary, so, but, this is your opportunity to burn up a little more
It's
time.
more exciting, because that yours costs more.
Yeah.
Hey, Spencer, just so you know, lunch will arrive here in about 10 to 15 minutes, so we'll probably pause a little bit, so.
Sounds great. Now, can I hijack the TVs again? I know I had
Yeah, that's fine.
everything,
Is it not?
I had it up just before, and perfect.
I think she's
there we go.
changing it right now.
Awesome, thank you. I,
Didn't have the road plan on there, that's why.
There we go.
Very good, perfect. Well, I'm excited. We've got quite a few things that we're going to talk about today. Try to take you through everything in as concise of a manner as I can, and certainly welcome as many questions as possible. I will take you through a number of different things, not only just the renewal itself, and kind of our assessment there, and maybe some recommendations, and then maybe even some discussion that will ensue in terms of the rates that the city is actually charging from a budgetary perspective. Because again, as you'll remember, as a self-funded health plan, you have a liability that the city is responsible for, and then there's the actual reserve that the city has taken the time to build up, which I think is a critical element to all of this. So then it really comes down to the question, what does the city want to budget for, potential medical expenses next year? So we'll go through all those pieces, but I want to take you through a couple of data points that will lead to our recommendation overall of where we think the city should budget for health insurance next year. And I wanted to start with where we are this year. So if you look in the top right-hand corner in the blue box, what we're tracking is, again, how is the city running compared to where your budget is. Now, keep in mind, again, the city has a very healthy and a very robust reserve in place already. But so far this year, if we stopped the plan this year, the city would have added $312,597 to your budget, meaning that you budgeted higher than you're actually spending, which is a great thing. And if I project out where your claims are right now, for the remainder 2 months of the plan, I would anticipate about $330,000 going towards your reserve account for the remainder of this year. So again, so far this year, everything has run well. On a very high level, and not really going into too much detail, but a big portion of all of that is what we would call your large claims. So again, keep in mind that the city is responsible for the first $110,000 of any individual one person's claims. And what I would just highlight, and again, I like this report because again, it's not going to show you any individual detail, but it's going to show you kind of in a broad spectrum where the city is running, and I think there's an interesting trend. COVID certainly plays a role in some of this, but as you'll notice in the far left-hand column, so starting over here, back in 2019, the city had 29 large claimants that incurred about $3.5 million in claims, just on those 29 claimants. Then you go to 2020, you had 31 individuals that incurred $3.4 million. And then all of a sudden you start to notice in 2021 and in the current year, you drop to 19 and 12 individuals respectively, totaling $2.7 million and $1.3 million. So what I'm getting at is you're seeing your large claimants go down. Now, again, that can be for a number of different reasons. One of the big concerns that we have is that, everybody always talked about there was a little bit of a panic that it was COVID going to be really expensive. And it wasn't COVID per se that was expensive, but it was the lack of treatment that people sought. So now we were starting to catch cancer claimants, not in their early stages, but in their later stages, which, as we know, become more fatal and more expensive. And so one of the reasons why we have Quantum Health, your care coordinators, in there is because, again, that's an advocacy group that is working with your spouses, your employees, and their dependents to make sure that they're getting the care that they need at the right time and continuing to push that. So now that we're in a second year of what I would consider to be somewhat of a down cycle in terms of your overall cost, I think that that's fantastic news. So that's one other data element that I would point out. Another one that I think is helpful to understand is, again, I wanted to show you the large claims, but I also want to show you just your claims generally speaking, because again, not everybody is a large claimant, and you have all of those claims that are beneath the surface. And so I want to show you what we would call as your trend line. So this is going all the way back to 2020. And what we're doing is we're taking your gross medical claims paid. So this report is specifically focusing in on your gross medical claims that you've paid out. And if you look in the far right-hand corner, I'm going to show you two different numbers, but they're two different time periods. The far right number is your 24-month trend line. So I don't want to cherry pick. I want to look at as broad spectrum of a data point as I can and look at what your trend line is. And for a 24-month trend, you're sitting at 1.9% trend. Now, to put that into layman's terms, the industry trend, or what is expected for insurance nationally, is anywhere from 8 to 10%. And that has been somewhat higher during COVID years. So another way to put that is the city is running, on a good estimate, about 6% lower than the rest of the country in terms of overall trend. Now, that's one data point. Now, I'll take a second data point, and that is your 12-month trend line. So instead of looking at a very big picture, I'm going to narrow that scope down just a little bit. And I'm going to look at your 12-month trend line. Your 12-month trend line is even better than that. You're sitting at a 0.5 point increase, meaning that, again, the city is seeing about an inflation rate of about 0.5 point. So that data point is medical only. I want to switch over and show you the pharmacy side. Arguably, one of my bigger concerns that keeps me up at night is probably pharmacy more than medical. We are seeing greater trend increases on the pharmacy side, due in part to some pretty amazing drugs that are coming out into the marketplace. I mean, we're talking about drugs that will, gene therapy, some of these will I think, change people's lives in terms of what they're capable of doing. But because they're going to do that, there is going to be a price tag that comes along with that. And so I do anticipate that pharmacy spend will continue to rise. Now, your pharmacy spend, in particular, on a 24-month trend line, the city has actually seen a deflationary rate of 6% in terms of your overall pharmacy costs. So your pharmacy costs are going down. Now, I'm going to just stick with 6% because the 12-month trend line is far better. And I would just argue is probably somewhat of an outlier, but you're at a 27% decrease in your pharmacy spend over that time. Now, just very quickly, one of the reasons I believe that to be the case is, for a couple of different reasons, but the main reason being is that, again, we're doing a couple of different programs that are installed on your program. Again, we consider ourselves to be more of a data and technology firm than anything else. We've built out a program through Novo Connection where we are ingesting all of your pharmacy data and making sure that Magellan, who is your pharmacy benefit manager, they're the ones processing all of your pharmacy claims, that they're performing the way that they should, but that we're saving as many dollars as we can. So last year alone, we were able to save about $180,000 on your pharmacy spend by doing something called patient advocacy or alternate funding. Basically, in a nutshell, we are working with the member to ensure that the cost that the city is paying for a prescription is, I think, fair and accurate. There's a lot of games that are being played on the pharmacy side to maximize revenue, and I think that comes at the expense of, in this case, the taxpayer of North Platte. So that was $170,000 or $180,000 last year. Of interest, that was for all of 2022. One thing that I want to just point out, for the first month of 2023, this program saved $30,000 alone in January of this year. We have a number of individuals taking some markedly very expensive medications. And again, this program alone, I think, is garnering in a lot of potential savings that the city would otherwise pay for. So I want to pause for a second. I know I've talked about trend. I've talked about pharmacy costs. I really do want to make this a work session. Does anybody have any questions as it relates?
So,
Please.
I have several questions. Can you explain to me exactly how that pharmacy program saves money? Does it pull from, more of a mail-in type of a pharmacy, or is it, how does that exactly work?
Yeah, no, that's a good question. So there are, in a nutshell, there's a game that is played by the pharmaceutical companies. They know that if they can basically get members over their deductible and their out-of-pocket, which in today's day and age have markedly grown, $4,000 or $5,000, and most of those members are going to hit their out-of-pocket maximum because of the medications that they're taking. So what the pharmacy company does is they'll say, look, I will give you a coupon card for $6,000. Cover and pay for your out-of-pocket medication, so you, the member, you have no out-of-pocket expense. All the while, on the back end, we're going to charge $80,000, $90,000, $200,000, whatever it is for that medication. So they shield the member, but then they soak the insurance company for the remaining amount. So that's kind of how that program works in a nutshell.
So it's more of a rebate type of a deal, essentially.
Yeah, it's like a rebate. Yeah, you're essentially shielding the member from the actual cost. Now, the member walks away happy because they're not paying anything for their medication. Now, most insurance companies, when it's United Healthcare or Cigna or whoever, they're gonna hit those costs, and then they're gonna pass those costs along in the renewal time. But because the city is a self-funded health plan, that affords us a pretty unique opportunity to say, wait a second, we're not going to do that game anymore. So now what we're doing is we are working directly with the member. So when we reach out to those patient advocacy programs, instead of saying, and the first question they're always going to ask is, what is your deductible and out-of-pocket maximum? Our response back to them is, no, we're not going to give that information to you. We want to know how much money are you willing to give for this program to offset the cost of this medication. So that way, again, we're shielding the member, but then we're also shielding the city from additional exposure. And what's remarkable to me is when you look at these medications, I mean, specifically one of them, you've got that the medication is $13,000 for a single month fill. They actually were able to cover that cost entirely, where the member paid nothing and the plan paid nothing for that medication. Does that help answer your question, Brad?
A little bit, it does, yes.
Okay. Anything else I can do to help clarify that?
No, I think that answers that.
Very
how
good.
That works. You talked about the trend line being under 2% in the increase, correct?
Correct, yes.
All right. Where did we start? Because if we started at $1 million and everybody else is at $500,000, we increased 2%, they increased 10%, we're still not ahead of the game. So does that question make sense?
It does. So you're basically saying, okay, so there's the city's trend, so
Right.
where the city is at, and where is the national average in terms of
Correct.
overall cost. So here's what I will do. I will go back. So Kaiser Family comes out with a really great study every single year where they show the average cost and they break it out. They break out the levels between PPOs, HDHPs, a variety of different plans. They also kind of break that out via both kind of rural and urban settings, so all of those things to take into consideration. What I will tell you, so I will, if I can follow up with you on that.
Oh, yeah, for sure.
So I will follow, actually, here, let me grab my notepad.
Yeah, I didn't expect you to have those numbers off the top of your head.
I have a lot of numbers in my head. And so anyways, but I want to make sure I give you a fair and accurate one. So I will give you what the national average. Now, I know one study that we did is we looked at all of the municipalities in the state of Nebraska. Because I think that, again, we can look anecdotally at the nation, and North Platte's going to be different. And I'm going to explain in a minute maybe why North Platte's particularly in a unique situation.
Yeah, comparing to Nebraska municipalities would be a lot better data
Yes.
point, so I'd appreciate that.
And we actually already have that. So
Okay,
so I will share kind of the findings of that one. And as a side note, one thing that I want to just highlight is in terms of a lot of the data that you'll see on that report, you'll note most of those are clients of ours. We have a pretty big footprint here in the state, not only including cities and municipalities, but actually, this is part of the reason why I have Ryan here, is one of his clients is one of the largest state entities. So we even have state of Nebraska departments that are clients of ours. So I think it's a pretty good relevant data point to not only look at what your deductible is, because you want to compare a couple of points. You want to compare what's your deductible, what's your out-of-pocket maximum, what's the overall plan design, what's the overall cost, and then location is another big part of that.
Yep, perfect.
So, great question.
So last time we talked about, tracking HbA1c, breast cancer screening, colorectal cancer screening, those kinds of things. You said you were working on the analytics side to develop that. Have you guys gotten any farther on that, or where are you at with that?
Again, another good question. And some of these I'm going to be able to answer because I've got the data. So in terms of what we want to look at, and again, looking at chronic conditions, and maybe hopefully again, this is the question that you're asking. So yes, so as a part of what we are building out in terms of all the data, so what you're seeing up on your screen, just as a clarifying point, this is a data system that we have built out. Again, we believe that data is a critical element to all of this, especially owning your own self-funded health plan. So all the data that's in this platform is data that's coming directly in from the third-party administrator and your pharmacy benefit manager. And again, the reason we believe this is important is because I feel like you should be able to ask me a question and I should have the data at my fingertips and I don't have to go through anybody to get it. So that's why we built this program out. Now, Brad, to answer your question, I'm going to adjust. No, I think I'll leave the time parameters. You'll note the time parameters up in the top. This is from January 31st of 2021 through January 30th of 2023. So just note that. And I can adjust those timeframes as we see fit. But in terms of type 2 diabetes, hypertension, these are the different chronic conditions that exist within the North Platte population. So you have 44 individuals with type 2 diabetes, 120 with hypertension, 22 with overweight and obesity, 7 arterial fibrillation, 15 heart disease, so on and so forth. So Brad, this is something that we are watching and monitoring. One other thing, and I'll just kind of fast forward and skip through to this. Another way to answer your question is that, again, the care coordinators, one of the things that they're going to be doing is they're going to be looking to engage your population that specifically have these different disease states because, again, keep in mind, the city is paying for an enhanced service. You're paying for a white glove call center to catch these various different things. Now, what makes Quantum unique is that you have a pod of 30 care coordinators, more specifically, they don't just answer the phone and answer questions, they are nurse case managers. And so the engagement in terms of those with chronic conditions is off the charts. But more specifically, I would even take that one step further and say your concern should be just in your high risk. It is your chronic conditions, those people who are going to be ongoing, but also your large risk, of which Quantum has had 92% engagement, averaging 14 calls with those individuals that are considered high risk. So, Brad, any other follow-up questions to that?
That does help a little bit. It sounds like you guys are heading the right way with your analytics and starting to develop that. So the care coordinators are actually interacting with your higher risk condition management stuff.
Correct. Yeah, and actually, one of the
Are
nice...
they being proactive, or is it more of a reactive based type?
No, so this is, again, one of the reasons why we believe Quantum is as powerful as they are. So, again, let me back up and also give some background in really who Quantum is. So Quantum is what we would consider the gold standard in care coordination and navigation. So the city of North Platte has completely unplugged the call center from the insurance company. So as you know, Meritain Health, who is a subsidiary of Aetna, is your third-party administrator. They're the ones processing and paying claims. I would make an argument that every single call center run by an insurance company is terrible. And the data bears that out. The Net Promoter Score for the average insurance company in this country is an 18. To give you a data point, Ritz-Carlton Hotels sits at a 72 from a Net Promoter Score. Quantum is sitting at a 74. Actually, some of the larger clients that they've picked up, they've got Honda Motor Corp, Abbott Labs. They just picked up one of the largest U.S. airlines in the country as one of their new clients. So again, the idea is that the healthcare system, in a sense, is broken, and so we want to fix that. Now, Brad, going back to your question more specifically, is are they proactive? So one of the trademarks that Quantum has is what they call real-time intercept. So sadly, in our country, when providers reach out for a different procedure, they call the insurance company and say, "I've got Spencer, he's got cancer, and we want to do this type of do this type of chemo regimen. Is it approved or not?" Most insurance companies take that data and they don't really do anything with it. They just say, "Oh yeah, Spencer's got coverage. Oh yeah, if he's got cancer, yeah, absolutely. That will be covered and paid for." Nobody mines that data to actually do proactive outreach. So what Quantum does is they immediately take that phone call, and because they're sitting in a pod of 30 care coordinators, they're all sitting next to each other. That patient representative is going to transfer them over to a nurse case manager, do a warm transfer. They're literally sitting right next to each other. And what they're going to start to do is they're going to immediately start to engage that provider with a myriad of different services to make sure that member is being taken care of. Actually, I'm surprised I didn't even think about this one, but you actually have a really good example that just hit the city of North Platte just recently. You have a member that I actually spoke to on the phone directly who their spouse, I want to be very careful, their spouse is going through what could be a $1 million procedure, a very, very expensive procedure. The city offers a benefit through what's called a transplant carve-out, where we actually remove that risk entirely from the self-funded health plan. Now, the member called in, asked for services, and we were able to not only engage with them, but make sure that they were directed to a centers of excellence where not only would their travel costs be covered, but they have no deductible and no out-of-pocket expense. So you have a member right now that's going to be going in for a $1 million procedure and isn't going to pay anything for it, and quite frankly, the city's not going to pay anything other than your premium for it either. So that's just one example that actually came to mind. This was actually just a few weeks ago, and that's ongoing right now. So hopefully, Brad, I wanted to give you kind of a few anecdotal stories. Does that help?
No, I appreciate that.
You bet.
I'll let you off the hook too. That's my final question, so.
One other thing, just on that note, is one of the things we say with the program is you really bend the trend of insurance claims, as we've seen over the last few years with what's occurred there. When individuals call in or doctors call in to pre-certify, at that point, the care coordinators start that engagement process. They start the discussion with the individual. They figure out, okay, what's going on? How can we help you more? How can we help you better? How do we look at best-in-class areas to go that might cost less, be less expensive, those types of things. So it's it is, I would say, as proactive as it gets. It's real time in terms of identifying, okay, what's out there, what medium to large claims might be of significance here, and how can we help? Not only help the individual, help the employee, help the member, but also help the plan and the program to reduce those costs. So,
That's a little more of a reactive, something's happening there, and then they get involved in that. Proactive, I think, from my definition, would be like, hey, you guys, you're behind on your colorectal cancer screening. Let's go get you checked out, make sure there aren't any problems. You know, that's kind of how
Yeah.
I define that. You know, but
Yeah,
there's several different ways to look at that.
yeah, and definitely from a wellness perspective and those types of things, yes, reaching out in advance. What I would say, just from a kind of here's how the industry is right now. Oftentimes, what Spencer referred to, those call centers, the administrators, the TPAs that are looking at things, they're getting that data after the first claims come in.
Right.
So they're getting that data sometimes 2, sometimes 3 months down the road, and then they're going back and trying to, hey, what can we do to help out the situation, to help out the claim? But with the real time when they call in, it really does significantly bend the trend, which is something we've seen in the last few years. So anyway,
Thanks, guys.
yeah.
I've got a follow-up question on engagement as well. If you could talk to us, one thing I'm trying to understand is there's financial engagement consultation, and then there's also healthcare related engagement. I'm assuming that both of those things go on. If you could talk about how that is handled in terms of helping people get to the right providers, do the right preventative things, all that, and then also helping them get the better deal or whatever, like you referred to, and then also how local and non-local providers enter into that, or regional and non-local providers enter into that too.
Ty, you ask a good question, and I'm going to give you. I want to give you as open and honest of an answer as I can give. I'm going to preface I'm going to preface my answer with. We are. Oh, and if we have lunch, if we want to break for lunch,
Take a break and then-
I mean, or Ty, if you want.
Answer the question. and
Okay,
then we'll-
very good. All right. So I give this statement with, we are agnostic in terms of your program. We will put together the best program that we can in terms of the data that supports it. We work with a number of clients through the state of Nebraska, through the state of Wyoming. We work in very rural areas, and we even have clients of ours that are rural hospitals. So we see the gamut from the city taxpayer to the hospital themselves. So the next statement that I want to give is, again, as we have gone through this, and I'm going to answer your question. It might take so we might kind of parse this up. We did a deep analysis in terms of your network. So there's kinds of two sides to this. There's the actual network that we're utilizing, and then there's a cash pay solution. So one of the solutions that we've deployed with the city of North Platte is where we've discovered providers hate working with insurance companies, and I don't quite frankly blame them for that. And what we have found is that if we can do a pre-negotiated settlement with a provider, so they are paid upfront prior to the procedure, not only are they willing to take a pretty sharp discount for that procedure, because then they don't have to submit anything on the back end. And I'll give you a specific example, actually. Just a few minutes ago, a member came to me and said that they negotiated a cash price for an MRI. It was outside of North Platte. They ended up paying $675 for that MRI. They did receive a quote here locally for about $3,000 for that same MRI. And so, again, I want to make sure that members are getting that procedures for the best overall cost that they possibly can, because a rising tide raises all boats. If we can make it affordable for the member, we make it affordable for the city and ultimately the taxpayer. So there's that side of it. So already deployed on your plan, any member can call any provider and say, look, can I pay cash for this procedure, get a cash discount? And not only will our team help negotiate that price, making sure that we're benching that against national norms so that we're getting a fair price for it, and they do that negotiation on behalf of your member, their spouses and dependents, doesn't matter who it is. And then we do all the paperwork on the back end to submit that claim through the insurance company so that it ultimately goes against deductibles and out-of-pockets. So there's that half of your question, Ty. I would say cash pay, it's phenomenal. And not only have we noticed that, the city has actually had a couple of claims, not only just in MRIs, but we also had we had a reconstructive surgery, I'll call it, that was going to be in the ballpark of about $30,000. We did cash negotiation. Now they of course traveled to Lincoln, I believe, and we ended up paying a substantial amount less than that. I think it actually came out to about $10,000. So cash pay, I think, is a great thing. But we try to make it lucrative for both member and the provider. Again, we recognize that there's somebody else, there's another dinner table on the other side. Now, that's half of it. The second half is the network that the city is utilizing. So so right now the city is utilizing the Aetna network to garner in discounts. Just if anybody walks in off the street to do that. I want to show you a couple of different reports, and like I said, if we need to break this answer up, I'm happy to do that. But I want to show you something interesting. So one of the solutions that has been prescribed to the city is one through kind of a coalition. It would still be self-funded, but basically the backbone of the program would be utilizing the Midlands Choice Network. The Midlands Choice Network is a network that's local here in Nebraska. They're owned by a couple of the major hospital systems back east. And if anybody will remember, actually the city of North Platte, just up until 2021, was actually on the Midlands Choice Network. I want to show you something of interest. We did a full claims reprice where we looked at every single claim, and because Meritain has a partnership with Midlands, if the city said, look, we want to go back to the Midlands Choice Network, great, we'll do it. One thing that I would just say is I don't know if the data bears that out. So we analyzed over $6.5 million worth of City of North Platte claims. And I want to take you in and just basically show you, kind of the end result. Right now, with the Aetna PPO discount, we're looking at about 29.3% discount through Aetna. Midlands Choice came back at about 23.6%. So that's one data point that I think is relevant. Another one that I think is of interest is not just that one, but where was the city prior to this? Because we actually have that data. We have the data of where the city was in 2020 versus 2021. And so what I was able to do is pull up one of your old discount evaluations. I think this is of interest. So if you look at the Midlands Choice Network, so this would be for the year 2020. If you look, Midlands Choice was garnering in about a 22% discount, which kind of seems to fall in line somewhat close to what we're seeing now. Again, I would probably venture to guess Midlands Choice probably has gained a point or two, so it wouldn't surprise me if Midlands was probably at about 23%.
Excuse me, point of clarification.
Yeah,
Are you
please.
saying 22% discount off the clinician's charge? Is that what you're saying?
Bill charge is correct.
Okay.
And a great point. So I think that's good to keep in mind. So roughly about 22% average. Aetna is coming in, and this is again 2021 data, but Aetna's coming in at about 26%. This is again live City of North Platte data 2020 to 2021 and where those network discounts came in. There's this half of it, and again, in a desire to be extremely sensitive, but I think it's of interesting point. You have where the overall discount is, but I will tell you right now, the second that anybody moves east or west, that discount really jumps, because I will tell you something that I found through all of the data that I dug through, and I just want to show you. I spent quite a bit of time going through a lot of different analyses. What I found, now this is through Midlands, is that if you look at the North Platte zip code, Midlands Choice. So again, we're getting rid of Omaha, we're getting rid of Lincoln, we're getting rid of Kearney. We are looking and we're kind of zeroing in. We're getting about a 6.2% discount. Again, this is through Midlands. This is not through Aetna. We would get about a 6.2% discount at the inpatient hospital level, 7.3% at outpatient, and 38.1% at physician. Physician typically is a little bit of a higher discount. So effectively, here in North Platte, you're going to get about a 7% discount. Now, I want to preface that with, again, any rural hospital is going to have, there's just not going to be a lot of discounts there. There's just not a lot of competition. And again, they have different cost outlays. There is charitable work that's oftentimes done. So, I mean, again, I don't think that that's anything outside of the norm. However, the second you move to Kearney or Grand Island, that discount jumps from 6% to 21%. And again, this is Midlands Choice reported data. And then the second you move from Kearney, Grand Island, and you move to Omaha or Lincoln, you're at 31%. I can tell you anecdotally, if you move to Denver, it's in the ballpark of about 40%. So one thing that I really feel like can be achieved here is, from a network perspective, I think that Aetna is by far the best choice in terms of overall discounts. Now, I have been told through some of my discussions, we've had a lot of different negotiations. that maybe Aetna isn't the right one in terms of the overall discount that is had. I will tell you, we're talking about 6%. Aetna's going to be very close to that. Now, in terms of going anywhere else, you can get a little bit of a steeper discount by going elsewhere. What I would like to do is, I think a rising tide raises all boats. I fully recognize that Great Plains Health is a local employer and that there's a lot of funds that go through that are very beneficial to the city of North Platte. We have had discussions once before, and I would like to reignite some of those conversations because it could be possible, if all parties were amenable, to do like a direct discount where the city of North Platte is taking a discount outside of Midlands, outside of Aetna, on behalf of the city. Now, with some of these data points, I think it helps hold in where I think a reasonable expectation is. But I think if we could accomplish something along those lines, I think it would be beneficial for everybody. So let me pause there. Ty, I know I just gave you a loaded answer.
Just to share with the council, I mean, something I have a general concern about it, and as you know, the Benefits Committee, we've been trying to, I mean, this is complex stuff for those of us who don't work with health insurance every day. I think it's complex stuff for those who do, actually. But, you know, I mean, what I'm worried about is if okay, let's say we have a car dealer here in town, and they can sell a pickup for a certain amount, and then we call Omaha, and they say, well, gosh, we'll sell it to you for $3,000 cheaper because, you know, what do we care if you buy it, we're going to make a little extra profit that we wouldn't have made otherwise, so we really don't care if you're helping pay for our lights and our employees and our overhead, because that's just an extra pickup we wouldn't sell otherwise. And so then it compounds the problem for the local provider because the profitable services are leaving the community. And I still think I mean, obviously employees need the right care and their choice in care, and I don't want us to lose sight of that because I still think that's the most important, is that they're being taken care of and they have their own choices in it. But I am, and this isn't a criticism of APTA because I think they're working to try to drive our costs down. But I have a real general concern overall, and I think we've got to figure out a way to break this general concern of services that can be done here that people would like to have done here that are moving out of the community because of a cash deal they can cut there. I think we got to work harder on coming back and trying to cut those deals here locally. And then we're just spiraling the cost factor for the local providers, which then is just elevating the cost on the other side. And I think there's a lot of that I think there's a lot of that going on here that concerns me, that it's part of the eventual bigger problem. And so I think anything we can do to focus on that and crack it, again, that's not a criticism of you guys. You're trying to drive our costs down because they were a mess years ago. So I guess that's an assessment I have of the situation.
Ty, I do want, but I want to say, no, at no point, Ty, did I think anything you said. I agree wholeheartedly with it. There is a balance that can be achieved where, again, the city has to look after the city and the taxpayer and making sure that you're getting an affordable procedure at the right price. Now, the city's in a unique position because you want to balance that with a very large employer in your community and making sure that, as I always like to say, their dinner table is being taken care of as well. You know, we all have families, we all have dinner tables, and again, that's something that I completely understand. But I think that, yeah, there could be some negotiation that could occur where maybe we could say, look, we don't want to ship these individuals out to get more affordable care, but I do think that maybe a unique discount to the city would be in everybody's interest. Anyways, but go ahead. There might have.
I was just going to make a comment. I was visiting with a friend in Colorado. We were comparing the Medicare programs, and you're exactly right. I mean, people that live in the Midwest were limited by our zip code. You go east, they got a lot more choices.
Yeah.
Colorado, it was amazing the choices she had. I'm going, wait a minute, I'm moving.
Well, we can grow our population here, Donna. That will help solve it.
I don't know if we can do it fast enough.
Okay, everybody, before we get off into any more questions,
Yeah.
Anybody who would like to grab some food, go grab it before it gets cold. Spencer, sorry, you got to stay up there and answer questions.
Okay, I'll say.
But Jim, go ahead and ask your question.
Well, I was just gonna make a comment, you know, you look at this thing as dollars and cents, but, you know, I've been through cancer, and I'll be darned, I did my cancer treatment here, and, you know, I'm not interested in going to Kearney, travel an hour and a half, travel 3 hours to Denver, you know, you get that chemotherapy, come back sick as a dog. I'm just not gonna do that. Makes a big difference. You can get the therapy here, go on home and recover. I actually was working full-time. I didn't wanna go to Denver and do my treatment. I had a job to do. So having access locally, there's a factor over and above just dollars and cents. That's all I'm trying to say.
I think that's a good point. Yeah. Any other questions anybody has on that?
So in these conversations with the doctor and patient or whoever, do they ever talk about lifestyle changes, maybe pertaining to your illnesses? And then is there any discussion about alternative medicines?
Yeah.
Hey, guys, would you guys remind talking the mic, because we probably do have people watching from
Yeah.
home,
Oh, sorry. I'll try to make
Sorry.
sure. Yeah, keep
Yeah.
that. I'll just keep this close. So good question. Just to reiterate the question, just in case. So the first question I had is, are the care coordinators, are they working with members and their spouses to try to induce lifestyle changes? And again, they're going to try to do that where they can. These are medical professionals. You do have a nurse case manager. So as it relates to a good example that comes to mind immediately would be like diabetes. Again, they are going to encourage proactively on, making food choices, managing A1Cs. A surprisingly big issue that we find in this country is that people aren't testing their blood sugars as regularly as they should. A data point that the care coordinators have is how rapidly individuals are filling their test strips. So I can tell in the data whether somebody is actually testing their blood sugars as they should, because they're either filling their test strips as they should or they're not. So they're going to make recommendations there. In terms of alternative medicine, the care coordinators probably aren't going to go down that road very far. Now, there are some procedures, chiropractic work and some others, that are eligible under the City of North Platte plan. But in terms of any real alternative medicine, the care coordinators probably aren't going to go down that path very far. Does that help answer your question?
It does, and that's kind of what I thought, but.
Yes, it's a delicate balance. So that's a great question. Anybody else have any other questions on the network front? Okay, very good. So I think kind of going back to the overall point, what I would like to do with the Mayor's Council is really turn our attention more to, again, based on what I'm seeing, again, I think the network is where it should be if we depart North Platte. But I would like to induce, I think, to the point that Jim made, how can we, induce people to stay here and help them? And there's a myriad of different ways we can do that. We can structure the benefit structure. We can make some changes to induce that, especially if the hospital were willing to do a special arrangement with the city. And that's been done before. So I want to just I think all these are good discussion points. Any other questions there? I know this is really riveting stuff, and to Ty's point, this has taken 10 years of my life trying to get to this point. So anyways, well, very good. Well, let me switch over. We actually do have some really good news, and this is, I think, also going to do some discussion. But because of where the city is running and how everything has gone this year, I wanted to go into the renewal itself. And just talk at length about where our budget is, how that looks. So a couple of key elements. Right now, we believe that the city has a reserve account, so a rainy day fund of about $4.4 million. And I just want to commend the city because that is, I think, a really big accomplishment. Having a rainy day fund, being very conservative with the finances, looking after the taxpayer, I think are critical elements. So if in the event that we have a bad year, and for the city, they have come, the city's going to be able to tap this reserve account without really having to dive anywhere else. The other reason that we have this reserve account, again, when we took over years ago, the city did not have a reserve. And so one of our missions and one of our goals is to be conservative with the budgeting to make sure that we're filling up that reserve account. Now, we're at a point now where your average claim spend annually is about $5 million, give or take, for claims expense. And, we have always, in the actuaries that we've spoken to, they've always said a good rule of thumb is to have about a year's worth of claims in reserve. 4.4 million is a good amount. The other way that I try to look at it is worst case scenario. Let's say that you have $1 million laser, an individual who is particularly sick. And oftentimes if you have $1 million laser, that's probably going to be a 1 or 2 year event. So we're talking, potentially a $2 million hit over the course of 2 years, potentially worst case scenario. Now, like I mentioned before, we do have a transplant carve out on your group. Transplants tend to be one of the most expensive items, and so we have completely carved that out and put that on a fully insured rider. So like I said, right now you have an individual that is seeking that. It'll probably be anywhere from $750,000 to $1 million procedure. That will not hit the city's self-insured program. That goes to a fully insured program. So now that takes us to the question of where do we want to budget? Where do we want to be at? And I'm going to draw from some of the data points that I've already kind of touched on. So what I basically did is I took where I believe your year end is going to be, which is just a hair north of $5 million in total claims. We have about a 3% increase to your stop loss factors going into next year. One other item that I wanted to just touch on because I never forgot it. I thought it was a really great point. But last year, standing at this very podium, there were some concerns about the stop loss carrier that we had selected, which is HCC Tokyo Marine. They are the largest reinsurance carrier. They're A++ rated, but there was some concern about kind of keeping things local. So we are going to make a recommended change to your stop loss carrier for a number of reasons, but the main reason being is we had another one who was very competitive. As you all know, one of the big ways that we try to keep your costs down is we shop with over 30 A-rated stop loss markets every single year. And we do that in-house by our own team. Sometimes that's stop loss is often farmed out. There are hidden revenue streams that are often hidden inside stop loss fees because you can make a killing in stop loss. I always want to just reiterate that all of our stop loss quotes are always net of any type of rebate, commission, fee, override. Oftentimes there's kickbacks that can come back. We do not accept any of those. So we are going to make a recommended change to a stop loss carrier called Companion. They are based in South Carolina. They're not owned by anybody else. They're a U.S. domiciled reinsurance carrier. And they came in, quite frankly, with a really good stop loss quote. So all things considered, and especially if we move over to the vision program that Jan had brought up, there's like an extra $1.50 in savings because you were paying Meritain $1.50 PEPM for admin, so that will come out. I'm going to make a couple of other edits that will save an additional $1.85 on the admin. But basically, in a nutshell, your total fixed expense would come out to about $992. RX rebates, which is another piece that goes in here, $230,000. If I estimate your claim spend, now this $5.1 million, I'm not pulling that number, kind of out of thin air. I looked at your overall trend and you're in decreased territory. So theoretically, I would even feel comfortable saying, look, I think budgeting for $5 million in claims next year may not actually be that far off the mark given your trend. But again, I want to continue to be conservative in terms of how we're budgeting for the city. So this is where we start getting into open for discussion. I am estimating your claims increase at a 3% trend line, which is above where you're actually running. So I'm still being conservative with where I'm projecting your claim trend. If I took that and plus your fixed, plus your rebates, that would put you at about $5.9 million in total spend next year. If we did a 0% increase, we did not affect your budget, and we just left the rates as they are, I would anticipate budgetarily about a $46,000 surplus next year. You would be kind of redlining your budget pretty close. And if we had a worse year than we anticipated, you have a giant reserve account to offset that. One thing that was of discussion, and again, this is where I would love your feedback. If we, said, look, let's decrease the rates and let's do a 1% decrease. And again, this is all up for discussion. I would anticipate maybe about a $12,000 deficit, again, with my assumptions in there of where you could ultimately end up at. So we could look at a decrease. We could look at a 2%. Again, I don't want to tap the reserve too much. It is there for a reason. But I think that, a 1% decrease, a flat, would be prudent, especially in this market where most employers are looking at 5 to 10% increases. So I think the city's in a really great spot. So let me pause there. Questions from anybody in terms of our recommendation for setting budgetary numbers for next year?
Spencer, I'm sorry.
Go ahead.
Could you go through in a little more detail individual stop loss coverage, laser exposure, and aggregate stop loss coverage so I can understand what our coverages are on those?
Yeah, you bet. So again, the city has well, here, I'll actually pull up this spreadsheet and I'll do it this way because I think this will be helpful. So if you take, so just as a side note, this is our shop that we did on your behalf. There's a lot of numbers on here. I'll zoom in and but I want to kind of zoom out and give you the big picture. There was a number of carriers that quoted on your group this year. HCC certainly gave their quote. They were at a 5.2% increase. They were actually fairly competitive. But Companion was in a little bit of a better spot. So the city has elected so far, so I'm going to just kind of hone in on column 8, option 8. So the city has elected $110,000 specific deductible, meaning that the city of North Platte is responsible for the first $110,000 per individual member. That's not per occurrence, that's just per member in a calendar, in a 12-month period, $110,000. Once we have met $110,000, the city has also what's called an aggregating specific deductible, meaning that after the 110 is met, the next $135,000, whether that's one person or 10 people, once they've crossed over that 110,000, the next 135 is still borne by the city. So it's kind of a you have an individual specific deductible, and then you have like an overall group specific deductible of the next 135,000. Ty, any questions there?
Well, I don't know if I fully understand that. You might have to walk back. So what's
Sure,
the
sure.
135 again?
So
What's that? Okay, it's a,
yeah. So the 110 is per member.
Yep.
The 135 is over the whole city of North Platte. So every single member. So whoever crosses over 110, the next 135,000.
okay.
That could be one individual. So that could be one individual who hits well over $300,000 in claims, or it could be 10 people who have an additional, $10,000 above that threshold. We have a 12-18 spec contract. This is another important point to that. Most groups will do a run-in, potentially a 24-12 contract or a 12-15 contract. What that means in layman's terms is you're also defining to the stop-loss carrier what's your risk, what's your timetable. So a 12-15 spec contract means that you have 12 months to incur the claims, April. So you have the 12 months from April 1st to incur those claims, and then you have an additional 3 months or 6 months of run out to get those claims paid, because we know that there is a claims lag. So, and your contract, we have an additional 6 months of run out that basically we can go back 6 months later and apply a claim 6 months in arrears. Now, one reason that we have you on a run out contract versus a run in, because you could be on a 24-12, meaning that we're going to incur all the claims from the past 12 months and let those run in. The main reason we don't like that is because, again, we're locking your stop-loss carrier in, whether they like it or not, into this contract. And so if you have a large cancer claimant that pops up at the end of the year, they're eating those claims whether they like it or not. Oftentimes with a run-in contract, if the carrier sees those claims are going to come in and hit them, they'll do additional laser liability that I don't think is in the city's interest. So there's that side of it. Now, a few years ago, the city opted to go without ag coverage. So now I want to try to explain this in as easy terms as I can. So some groups, when they're self-funded, have ag protection, meaning anything from $1 up to $110,000. So that responsibility that the city has flows into an overall aggregating bucket. And oftentimes there's going to be a cap that's associated with an additional dollar amount that says, okay, if you reach $5 million in claims, the city's no longer responsible for that anymore. My problem fundamentally with ag coverage is that the city was paying near $50,000 in premium for ag coverage, and the city has only ever hit their ag one time, and the one time they hit it, the stop-loss carrier in the preceding year gave you like a 30% increase to the attachment point. It's very rare that a group actually hits their attachment point. Because the city has been prudent and financial in building up a reserve account and has $4.4 million. That's why I feel comfortable. Why would the city pay $50,000 in fixed expense for protection that you will probably never end up using anyways? So save that money, reserve it, and that's where the financial prudence comes in. So,
what would but if you're a couple $1 million in additional reserves, there's a cost with tying up that money too, right? So what, sure. If we were, now, another thing I'd like you to comment, I have had people tell me that the state of Nebraska has certain laws requiring certain aggregate requirements, so if you can address that.
You bet.
But what, if we were spending an extra $50,000 for that policy, what kind of reserve would become prudent versus the 4.4, let's say?
Couple of good questions in there. Let me back up. One other thing that I think is kind of also interesting about ag coverage is most ag coverage has $1 million cap on it. So the stop loss carrier will only reimburse $1 million. So if you have a terrible year and you exceed your ag by 2 million, the stop loss carrier is only going to reimburse you $1 million, and you're going to be responsible for the $1 million over that. Now, sometimes you can get a $2 million cap, but there's more premium involved with that. So again, I have a lot of fundamental issues with ag coverage because, again, if you can save for it and reserve for it, save yourself the fixed premium, and it might pay off once in a few years that if you actually had ag coverage. Now, the second piece regarding the state law. I went through, I noted where there is some language where it would seem to denote that ag coverage is required. I reached out specifically to the Nebraska Department of Insurance and actually spoke with the chair of the department and asked, does anybody need to have ag coverage? And the response that they came back to me is no. So I noted the law. I mean, I can see why somebody would think that. I really do. But when I spoke directly with the head of the Nebraska Department of Insurance, I've got an email chain, I'm happy to share it, where they said, that's out of our jurisdiction and out of our purview. So, again, I would say that that's probably a gray area. If the city thinks that they need ag coverage, I'm happy to get it for you. But from the language, directly from the Department of Nebraska, they said no. So it's a good question. Like I said, I reviewed the law. I reviewed it with our legal team. Again, keep in mind that all stop loss carriers have pretty extensive legal departments. So not only did I ask our ERISA counsel, but I asked HCC, largest reinsurance carrier, and they said they don't think that that's a requirement.
And I understand that you guys in the field are the experts on this. If I talk to other people in the insurance world, this is probably an area there's some philosophical differences on.
Sure.
Broker to broker, right?
100%.
It's fair to say.
I mean, yeah, I guess what I'm going to say is I'm going to advocate for you. Look, you're going to pay $50,000 in fixed fees. You're going to have $1 million cap. Does it make sense? It depends on your risk aversion. If you're worried about that $1 million, we call ag coverage, we call it good sleep at night coverage. Again, if that's something that you feel is pertinent for the city, that's great. I just, again, with a reserve that the city has, why spend an extra $50,000 annually? Now, Ty, you asked another question inside of that is where's a prudent reserve? Again, I have always, again, in everything I've understood talking to actuaries, a year's worth of claims is a good spot to be at. You're at $5 million. So a $4.4 million reserve, that's why I don't have any heartburn basically putting your budget at basically a net even, because if we run south, you've got money aside, and if we run still to the positive, more money goes into the reserve account. Time value of money, you're a banker, you get it. So that money could be maybe going somewhere else. I would just argue that, the city has benefited greatly from being self-funded. And even if you had ag protection, you have $1 million cap on that ag. So there is liability above and beyond that would still be prudent to have that reserve account. And I would probably still recommend probably where you're at. So anyways, and again, to your point, that's philosophical.
I tend to agree with you. On a much lower level, we self-insure a little bit, deductibles on automobiles. I'm a proponent of $1,000 deductible. Sorry, $1,000 deductible versus a $250 deductible, and pay the insurance company less money. So I think it sounds like our reserves is a good point, a year's worth of reserves, and saving $50,000 in that line, I think, is prudent. On a big picture budgetary, you talked about that a little bit, and you said a zero net increase would, if I'm not mistaken, we would have a $46,000 in surplus if we went at a zero budgetary increase this year. If we went a 1% below budget, we'd be in a deficit of about $12,000. In a big picture, if we have one more catastrophic claim than what we had last year, we would have to dip into reserves. At $110,000 per individual. So I think I wouldn't be a proponent of reducing the budget at this point, but possibly going at a zero if that makes sense.
Pete,
That's just observations.
I guess what I would tell you, claims do ebb and flow. You're right. If you have more large claimants, that's $110,000 on a $5 million claim spend. Even 3 large claimants is. I'm not trying to downplay, but on a $5 million claim spend, another $300,000 is. is not large. But again, it
Right.
depends because those claims are gonna ebb and flow.
Yeah, yeah, and it shows that we're trending down right now, but that could flip a switch in a season easily, you know, so just on a conservation period.
I want to make sure I understand, and so when we're looking at that total budget, that's what the city pays and the employee pays, right?
That's full rate, that's
Right,
correct.
so, I mean, if we were reducing 1%, we're the biggest payer of that 1% that's
Right.
getting the savings, and so it really becomes a function of how you handle. I agree with you at zero, but I just wanted to point out that the city is the one, is paying a big percentage of that total, and then, of course, the employee money with it as well. Yeah.
So that's full rate.
Yeah.
Yeah, that's full rate. Any other questions there? Oh, sorry, no, I'm sorry. I stepped off to the side, thank you. Ryan, did you was there anything you wanted to add? Okay. Any other questions that come as a result of those rates? So, okay, our recommendation, would be a 0% increase to your budgetary rates. Our recommendation would certainly be to move forward with the companion quote, and utilize them from a stop-loss carrier perspective. One other change that I would recommend, and this came out of the result of some of our network evaluation, and again, we will, if we need to make a change to administrators, if we need to make a change to networks, we are proponents of that. Again, if you're with Midland's Choice versus Aetna, it does not make a difference to me. Again, I try to reiterate this, that, we work on the city's behalf. We have our contract directly with the city, so regardless of the choice you make, it doesn't make a difference to me. But I wanted to just also point out that, again, through this, right now, the city of North Platte is on the Aetna PPO network. Kind of consider this to be the same as, even within, if you bought a Chevy Silverado, you've got various different trim levels of the Silverado. Same truck, same engine, well, anyways, we won't go down that road. But, basically, same vehicle, you can pick different trim packages. Within the Aetna network, it works very similar to that. You have the Aetna PPO network, which is one of their broad networks. However, the Aetna Choice POS2 network, or it's also affectionately known as CP2, we actually believe that there might even garner in an additional half point of savings, particularly if travel is there. Now, there is a change for that. There's a $2 PEPM increase to move from PPO to CP2. But based on your claims reprice, and again, this was looking at $6 million worth of claims, we believe that there would be about a $24,000 net increase in terms of discounts that the city would garner in from that. So, again, if I'm laying all the cards out on the table, I'd say, look, do a 0% increase on your budget. We would take, I would recommend the change to the CP2 network, certainly going forward with the fully insured vision program. And I think the city would be sitting in a pretty good spot. Now, over the course of the next year, again, I would love to continue to have very productive conversations directly with the hospital to say, hey, how can we, to the point that we've had, how can we collaborate in a way to help induce members to stay here locally and do that at an affordable price that benefits the taxpayer. So that's kind of my recommendation in a nutshell.
CP2, real quick. So you said $1 extra. What does that equate to? Because you said it could be a $24,000 savings, something like that. What is the $1 extra?
So that would
equate to?
so that would cost the city $5,616 annually, more money to tap into the CP2 network, with the savings at $24,000. So that would be including those fees. We would anticipate $24,000 in net savings back to the city in terms of additional discounts.
And you threw travel in there. Does it have travel perks?
No. So there's no, and Pete, I appreciate you catching me. So when I say travel I don't think that's going to have any impact on the discounts here locally. That's going to have an impact in terms of discounts as people travel to Grand Island, Kearney, Lincoln, Omaha. So we're going to see bigger discounts in the larger areas as people utilize that network. That's what I mean by travel. Now, again, the city, because you're a self-funded health plan, there's options that we could look at, in terms of inducements one way or the other.
Mm-hmm. Okay. Thank you.
You bet. Great question.
So, go ahead, Ty.
I could go on for hours with questions, so I'll try to keep it brief.
Mine might take a while, so go ahead.
Could you give us a general breakdown of the 992,000 fixed expenses, just how that kind of roughly breaks up?
Yeah, you bet. So that basically, again, the lion's share of that is of course going to be in stop loss fees. So for companion, like I said, I know these numbers are small. I'm happy, of course, these will all be shared. So in terms of overall fixed amount, there is $627,259 in individual stop loss fees. So the lion's share of that, 2/3 of that is going to go to companion. And then $365,256 is going to go towards Meritain, Quantum, network access fees, all of those things. So that's going to be built into the $365,000 that goes into the rest of that. And that's what gets you to the $992,515. Good question.
Okay, one more and then I'll do it. Okay.
I could tell you had one.
Yeah, no. You mentioned earlier, if you're going to get to this, I'll be patient, but some comparability looking at our total costs of single and family and how that compares to the other municipalities, just looking at from a total cost standpoint. And then secondarily, any thoughts we've talked a lot about, is there enough choice in our plan? And then I guess the third, final thing for me probably is Lane has mentioned a couple times, we've talked a little bit about a potential shift in the cycle. I'd like to know if we were looking to ever do a short cycle to get on calendar year ends or
Either
calendar
budget year.
from a budget standpoint, what does the environment for short cycle look like? So again, okay, that's okay. That's what I want to hear about. So those are the three final things I wanted to
So I'm going to full-throatedly and unequivocally, go against Jan. She's going to beat me up for it later. That's okay. I'll take it. Looking at the medical side, if you want to make a change to your plan year, again, that's not really that big of a deal. We philosophically, again, even in one company, we're going to have disagreements. And believe me, there's going to be some spirited discussion, and the 3.5-hour car ride back home. Again, basically, in terms of what it means, from a so the biggest piece is your stop loss carrier. That's the big piece. And so I know we had talked about potentially, again, what would make sense. So I guess just what I would tell you is we're amenable to do whatever's beneficial. If that's to move to January, great. I believe your budget year is October. Is that correct? So one recommendation that I would just make, because in terms of setting your budget, if we move to a 10-1 renewal, again, that's totally fine. But we would have your numbers probably prepared, roughly 60 days out. And I don't want to trip up your budgeting. And if that trips it up, so we could look at like a 7-1 renewal. So that way we have the renewal in place, it's ready to go, and then you know what your budgetary numbers are. So there's a couple of different ways we could do that. I would look to your guidance on, does 7-1 make sense? Does 1-1 make sense? Does 10-1 make sense? Again, we're amenable either way.
we were talking about, we figured there was a good reason that it's why it is. And so one of those things we talked about is the grass greener on the other side. And so we're interested in, if you remember, why we're on the state to begin with. 'Cause none of us were here for that.
I think you always have been.
Okay.
You've always
Because
been,
we
as
always
long
have
as
been,
we
okay.
have, yeah.
Always have been.
So just speaking of, so the answer was, that you guys you always have been.
And I would say, so budgetarily, normally, we know what the first 6 months is gonna be, cause we're on that. It's always the second 6 months of the year that we guess. And I'm not sure changing to October 1st, if we still don't get those rates until, let's say, January or July or August timeframe, we're already so deep into the budget process, it'd be pretty tough to switch up, so I'm not sure we'd gain a whole lot. I like to be spot on, and I'm not sure I'm ever gonna be able to be spot on, so. But the last 2 years, we've taken our trends, and where we've basically remained flat for the last couple of years in premiums, and that's kind of where we budgeted at. So that, it has been helpful that we know trending-wise where we've been at. Now, we could have a gotcha in the middle of next year, and we'd have to deal with that budgetarily, but, we've been trending pretty decent, so it's been easier to go flat than if you're always on a cycle where every year you're gonna have an increase. It's gonna be a 2% or a 5%, that's a little more difficult, but where we've been flat, it's been a little easier, so.
And then Ty, one of your other, I think you asked 3 questions, and I remember 2 of them, so forgive me. So the other one, no, I actually remember all 3 of them. The next one was in terms of comparability. I will send out an email to Lane. I'll kind of summarize everything, so that way I can answer Brad's question from earlier. I will answer that question and show kind of that comparability study. So that one I will get back to you on. And then the first one that you asked, and I would be great with this, is I believe you were referring to like a dual plan option. Again, the city offers one plan design. If you want to offer two plan designs, some groups will do like a PPO plan where you have co-pays, a low deductible. Maybe there's a spot in there where the city would like to do like a high deductible health plan with an HSA option. I will tell you that I'm covered under a high deductible health plan with an HSA option. It's beneficial to me in my situation. So I am personally a big fan of them. Now, they don't always work for everybody. And one thing that I would really caution on is, sometimes people will look at just what's the lowest premium, and they'll go with that plan, not fully knowing what that means to them. And so you've had a lot of people who are in a high deductible health plan and they owe a $4,000 hospital bill, and it kind of catches them off guard. Now, if you're prudent in saving towards an HSA, I think they're great vehicles. I'm not, again, philosophically a big proponent of HRAs. I think you're just self-funding a self-funded health plan. An HRA, health reimbursement account, is kind of a use it or lose it. You have the money put in, and if you don't use it that year, it's gone. The thing that I like about HSAs, it allows the employees or the employer contribute to that health savings account, and that money builds. There's an annual cap, but there's no overall cap. And it's a great benefit and can be. So if we wanted to look at a dual plan design option, we would welcome it.
And then any thoughts on there has been some discussion, I think, among the employee base about a +1 option versus family. Do you have any general thoughts on that?
Yeah, I mean, most of our groups, the city has kind of always been two-tier, and that's, kind of the way the city has always operated. A lot of my groups are 4-tier, that's kind of where they're at. They've got an employee spouse, employee child, and a family tier. That's a decent option. I think a 3-tier probably for the city, like if it was the goal of the city to move to maybe a 4-tier, I would probably stair step into a 3-tier and then a 4-tier. Just because, again, you push more pressure on the rates, because, again, we're budgeting for the overall same amount, but now we're adding another 3rd tier in there that's typically lower. So I think a 3-tier, which would just be an employee +1, and a family tier. Again, I would be great with that if that's a direction that the city would like to go, to offer a 3-tier rate. And then ultimately a 4-tier if that's where
I just comment to the group that as we've talked about this a little bit on the Benefit Review Committee, I think there's some thrust to look at this, but we also recognize that there's union contracts involved and there's a lot of complexities to it too. But this is an item we've been continuing to talk about.
Yeah, and to Spencer's point, where at the end of the day, we still have to have the same amount of money going into the bucket per se. Some may see a rate reduction, but some may see a rate increase, and so we're very cognizant of that as well. So it's gonna, it's not something you just say, here's 3 rates and you go with it. There's some thought process.
Yeah.
One of the things we've talked about is that how many, let's say, employed spouses are choosing to be insured at the city because it's family or single, and in essence, they could gain insurance at a low cost through their own employer, but it's no different to them because we only have the 2 tiers here.
I would just like to add, Spencer, I also used a HSA before Medicare, and I definitely did like it.
They're a good option. I always try to tell people, look, it's another great vehicle to save. You can't contribute to an HSA in Medicare years, but you can exhaust them.
I
And
still have one.
I've got 4 kids, and one of the things that I've learned about HSAs is that you can use it to pay for braces, and so I feel like my HSA account, it's looking really good right now, and my oldest is 8, and I think in just a few years it's gonna not look as great.
And also you have the option of, rather than spending down that HSA, you can just pay for your out-of-pocket. Just pay
Oh, absolutely.
another way.
Absolutely. Yeah.
Exactly. Yes,
They're versatile, but I just would want to make sure that everybody understood. There's kind of an old adage to HSAs that they're for the healthy, wealthy, and wise. And there's an element of truth to that. Like, you would just want to make sure that everybody understood, look, you're not going to have a $750 deductible. You're going to have a $2,000 deductible. And that you're going to want to make sure that you have the ability to pay for a large medical expense. If you don't have the money in your HSA, how would you pay for it? But again, there's a little bit of a gamble there where it's like, look, if you can, build up that account, you have the money in there. We work with a great HSA administrator that there's some investment options. So once you reach a certain limit, you could invest the money. So you could still get that account to grow. It's the only triple tax advantaged account that you can have.
I was gonna say, and for people to understand that, number one, they need to fund it, and it is a tax benefit to them to fund it.
Yeah, it will, the money goes in tax-free, the money grows tax-free, and as long as it's spent on medical expenses, it can be expended tax-free. Yeah.
So I would promote that option.
And if we did go that path, I would take your case managers would give guidance to the members on HSAs or no?
Well, in terms of like what they fund to the HSAs,
No, in terms of how to set one up, how to utilize it, and just an overall educational purpose on it.
they would be able to do light education, like on what an HSA is. Honestly, I would come out and do employee meetings. Like I would want to try to educate as best as I could to make it, hopefully help sink in on what it is. But then my recommendation would be is that the city sponsor an HSA account. And again, Don is here, so I'm just gonna turn my back for a
We'd have to
second.
do a lot of education for the employees,
We-
before we would ever enter into that.
Absolutely.
People are scared to death of all
Yep,
this stuff.
no, I agree.
You know, I think another thing too is, how many people in this country, in this town, live from paycheck to paycheck? And with a higher deductible, it sounds good, but, a $2,000 bill to someone who lives to paycheck, that becomes a critical issue. And it just, there's a spiral thing that can go into effect, so, I mean, it sounds good, but you have to, again, it has to be someone who is disciplined in their spending and, kind of smart on how to handle things financially, but you have to realize there's a good segment of our employees and our population, that's not that way. They live from paycheck to paycheck.
And so, yeah, we would want to educate there. And like I said, I think if the city sponsored an HSA account, you could deduct those deductions right out of payroll. And you could make it pretty seamless. But to Jim's point, and it's a good point, I think if we offered both plans, we would really want to make sure that the employees understood, look, even though maybe the premium on this is lower, there's some risk to it. Now, the city could look to contribute to an HSA. And maybe help, do that. We have a couple of employer groups that they've made a one-time contribution up front to those HSAs. The downside or the potential risk that I don't think the city would quite have, you have a lot of long tenured employees, is you dump $1,000 into somebody's HSA and they leave tomorrow and it's their money. They walk away with it. But your tenure is long enough that you could say, look, maybe this first time, you go to, we're going to contribute on each pay period, we're going to contribute a set amount. But maybe the first year you say, look, just to kind of help people, we'll dump in $250, $500. Again, all options that could be discussed.
I just add on that, on the benefits review committee that's been meeting on a regular basis, this is an item that we've kept talking about. And I think we're generally looking at it from the perspective of, we need to recognize that the employees are a tremendous asset of the city. It's a very difficult hiring environment. And if anything, we see the HSA as a on the horizon potential alternative option that again gives employees more choice. And also you could design an HSA program in a way that it would encourage people to consider it with things like a better co-insurance agreement or potentially contributing to HSAs. I mean, there's all sorts of ways. And so the idea would be is if you layered that in ever to do it in a way where it's culturally positive in the employee base and it doesn't be perceived as, we're taking all this away from them to save a few bucks. And so I think you can take a long approach at layering that in with a good strategy. Yeah.
Agreed.
So I want to ask you about the PBM.
Yeah.
Who is the PBM in this scenario?
So yeah, your pharmacy benefit manager is Magellan RX.
Magellan RX. Okay, and which pharmacy chains are they associated with?
So and maybe what you're there are a lot of PBMs that are now being purchased, by large retail chains. CVS, who owns Aetna, they are one. You have a really big deal with United Healthcare and Walgreens. So one of the reasons that we have you with Magellan is that they are not owned by a retail pharmacy chain.
Okay. And if we wanted to select a different PBM, do we have that opportunity?
You do. What I would just show you, and again, just try to keep this light, and Mayor, these are really good questions. I want to just illustrate this for you. Again, all of the different programs that we have, built out for you are, again, we want to kind of consider ourselves to be more of a technology firm than anything else. So let me just, I want to show you your data. So one of the things that we can do, we have a number of different contracts with a number of different PBMs. And again, we're great with any of them. Our big problem is that the amount of hidden revenue and dark money that exists in the pharmacy world is pretty disgusting.
I'm asking about it.
To put it lightly. Again, there's a reason why one of the largest insurance, well, actually, the largest insurance company, United Healthcare, why they own a PBM, why the second largest insurance company is owned by a PBM, and why the third largest entity just merged with a PBM. I mean, again, the money that exists in this world is pretty outrageous. The contract that I will tell you that you're on, you are on a transparent pass-through contract. And I don't want to go too far into this because we get into the dark world, and to Ty's point, I'll stand here and talk as long as I want. My legs haven't given out quite yet. I'm kind of holding on to the podium. But what I will tell you is that some of the games that can be played that are pretty nefarious would be like spread pricing, just for one very quick example. In a nutshell, there's the price that your member sees at the counter when they go to pick up a medication. There's the price that the pharmacy charges the PBM. And then there's the price that the health insurance plan ultimately pays or reimburses the PBM for that particular prescription. And what I mean by spread pricing is that the PBM will inflate, so they'll reimburse the pharmacy $100 for a medication, but the average wholesale price may be $150 for that medication. So they turn around and they charge the city of North Platte $150, and they pocket $50 on that medication. It's a pretty disgusting game. So what we mean by transparent pass-through pricing is that basically Magellan is required to basically charge the city of North Platte the amount that they reimbursed the pharmacy for that medication. Now, for that, the city of North Platte is paying a dispensing fee to Magellan. Again, they have a kitchen table, and so they need to be paid. There's that side of it, but then there's also some of the performance guarantees. Now, a lot of the data that you're going to see in this, you're not going to see anywhere else because, again, most of this is information that the PBMs don't want you to have. Now, Magellan, when we went with them, they came to the city of North Platte and in their contract agreed to certain performance guarantees based on mail order, generic, and that's going to be in 30 and 90-day increments. And in there, they said, we promise to perform at a certain level. Most PBMs are not going to share this data. And so one of the areas, the reason why we think data is so critical is we want to show you where they are performing and where they're not. And Magellan right now, if you look at your contract overall, there are 3 areas where Magellan is actually falling underneath their contract. But there are a bunch of other areas where they're exceeding by a lot. So specialty generic, they're outperforming their contract by $8,000. On retail generic 30, they're outperforming by $4,000. This is data that you will not see anywhere else. And again, it's because that they don't want you to know how they're actually performing. But I can tell you, based on last month, that Magellan is performing from that metric. Anyways, I probably went off on a little bit more than what you asked, but Mayor, go ahead.
That's okay. So what's our current rate, our typical monthly pharmacy spend right now for the city of North Platte? What's typical?
I'll tell you the exact number. You're at about 17% overall spend. Last month, you spent $59,000 in pharmacy. The month before that, $150,000. So you're about 60, 70 grand a month.
Okay. And so then in your reporting, can you produce the top 10 medications that we're prescribing?
Yes, sir.
Can you see what the charge and collection rates are?
What is being paid?
What's the city being charged and what's being paid to the pharmacy?
Correct. Yeah, we can, yes. So here, I will take you right there. So there are your top drugs. Total cost, so we could look at it a couple different ways. I can, kind of manipulate the data however you see fit. Total cost, there's your total cost, your most expensive one. There's plan pay, copay, what tier it is. Like I said, we could kind of break that out in a couple of different ways. But yes, whatever way you want to look at the data, we could trim it that way.
Okay. Well, I'd be interested in seeing what the top 10 are, what the city is charged and what the pharmacy is paid.
Okay. So you're talking about, so you're kind of getting at spread pricing. Is that what I'm, okay.
Mm-hmm. So because the way this works and the way the PBMs make ridiculous sums of money in some cases is that exactly what Spencer talked about is they charge the city X and they pay the pharmacy Y, they collect the difference. And sometimes that is a drastic difference per prescription, like $100 per prescription. Sometimes it's very small, but a lot of times when they're abusing it, it's a drastic number. And you look at our local pharmacies, I know from from my other employer, approximately how many prescriptions go through this town in a day. And, you know, we'd be generating a very big spread if somebody was making $50 per prescription because of that spread. That's why I'm after those numbers. I want to see what it is. Because I know what usual and customary per pharmacy rate should be, roughly. So I want to see what the spread is.
Yeah.
So my next question is with regard to Midland's choice reimbursement. And this one can get deep, so everybody just bear with me here, sorry. Something similar occurs to what PBMs do with health insurance companies. So health insurance companies, I'm going to speak in generality here because there's all sorts of variances, but in essence, they go out and make contracts with providers. So whether it be doctors' offices, hospitals, rehab centers, whatever, they go out and they make contracts. And they agree to pay a certain percentage of overall charge. It varies drastically depending on what it is and where it is and all that sort of thing, which is why you get these very disparate numbers like Spencer mentioned in an MRI charge. So he mentioned a cost for an MRI in another community of $675, give or take some change. A cost in North Platte of $3,000. I would about guarantee you that MRI charge is from an outpatient MRI clinic, right? Most likely.
Most likely.
Yeah, okay. So they don't have to be open 365, 24/7. They don't have an ER. They don't do charity care. They get to decide who they take care of. They don't have any of the expenses of the hospital, basically, or they only have some of the expenses of the hospital. So that's what creates that disparity. But what insurance companies do is they go and they make, generally, they go and they make agreements with hospitals, providers, and so on and so forth, and they agree to pay a percent of charges. And that's what causes, ultimately, these wonky-looking charges when you go to hospitals and doctors' offices where you get the $70 aspirins. It's because the hospital has to ramp up this charge because their percentage of charge paid by the insurance company is much lower, like 35%. So I'm going through that long and complex explanation to get to this question. Mm-hmm. You said that Midland's Choice discount in this area was between 6 and 7.5%, if I read your spreadsheet right.
Correct.
Okay. Now, I know what clinics and the hospital is generally getting reimbursed by Midland's, and it's a hell of a lot less than 6 or 7% discount.
Okay.
Based on the base charge. So my question is, what charge are you talking about with regard to that 6 to 7% discount? Is that the negotiated rate? Is that the published standard charge for the facility or the clinic? What is that rate number?
So my understanding, and this is a really good question. Actually, I wanted to show you. I won't go down that. Well, actually, really quick, I want to show you this because it really speaks to what the mayor is talking about. And the Wall Street Journal has done a nice kind of expose, if you will, on the various different charges and to the point that the mayor is bringing up. So this is in regards to Sutter Health in California, and like I said, I'm just using this more anecdotally. So to really back up what the mayor is saying. The difference in what is paid for a varying different procedure in a large metropolitan area, this is Sutter Health in California, that the non-cervical spine fusion at the same facility costs anywhere, there's a difference of $223,000. And it depends on who your insurance company is, depends on Medicare, Medicaid, there's a lot of different factors that go into that. So what is paid ultimately for that procedure really is different. Hip or knee replacement, $78,000. Cesarean section, $37,000. So all this to say, I agree with the mayor that, again, there's a lot of different reasons that go into what is ultimately paid for a procedure. And that's really what I wanted to try to get to through my analysis is I don't really care what the discount is. I want to know what ultimately would be paid for a procedure between Midlands or Aetna as an example. My understanding, to try to answer your question as directly as I can, my understanding was that when we did this reprice, that they did a full and complete reprice on each claim, looking at the CPT code, what would have been billed and what would have ultimately been charged for that procedure to ultimately come up to that discount. So where I may be...
So what would have been charged, not what would have been paid? That's the critical question here.
I guess I will have to go back and ask that question. I want to make sure, because that is a very specific answer.
Based on your numbers, it about has to be what would have been charged, not what it would have been paid.
Okay.
So it would be interesting to know is what that discount is based on what would have actually have been paid.
So
It's
you're,
going to be a much different number.
so you're asking for net paid. What, again, forget the discount.
As a percentage, yeah.
Yeah, really get to what would have ultimately net been paid for that.
Charge versus what was actually paid.
Now, I guess where I want to, and I'm going to go back and I want to ask these questions of the network department, because I've worked with both, and, 2 million.
And the reason that I'm questioning Spencer about this,
Please.
everybody, just so you're clear, is this is what drives up the cost of healthcare. It's these people that stand in the middle. And I'm not, and we need them to process claims in some cases and things like that. But it's those ever-increasing percentages that are not landing in the hands of the providers, and they're not landing in the hands of the patient. They're landing in the hands of the people in the middle. And that's why I'm pushing him to get to these percentages, because we need to understand that in order to make the best decision for everyone concerned. So, sorry.
No, I totally agree. So here's what I would like to do. I think the mayor asked good questions. So I'm going to go back to the network department because I want to verify net paid. The effect net, what would have been paid. And under the current arrangement that the city finds themselves on, you know, again, we can pivot to the Midland. If we ultimately come to and say, well, we actually think that the net paid for that procedure would be better under Midlands, we can make that choice pretty quickly. So I want to go back and if I may, as a takeaway, I would like to have that as a takeaway.
Yeah, that's
if
fine,
that's okay.
because it will take a bit to get to that. So. Sure, why not? You gotta get up here by the microphone, though.
To Spencer's point with
And
Midland.
tell us who you are.
Oh, Tanner Patera, 3821 Sugarberry Court. I work for Hub International. No, I just, to Spencer's point, so, I mean, I understand what you're trying to get to, but from a standpoint of looking at in Nebraska network choices and what costs more, Midlands typically, no matter what TPA, whether you use Meritain, UMR, et cetera, costs more. So, I mean, from a standpoint of the Aetna network versus Midlands, it's going to cost the employer more. Whether, from the standpoint of what the provider gets, that depends on the provider, just for the same reasons you did. So, I just wanted to point out that Midlands typically is just more cost to the employers in Nebraska. So, it is a wider network and more acceptable.
You might think that I would have known that based on my questioning, but thank you for bringing it up.
Could I maybe re-understand why Midlands is being used as the comparison point here to Aetna?
Yeah, I mean, so one of the, to my understanding, one of the recommendations that's coming potentially, or that's being advocated for, so just to back up a little bit further, Midlands Choice, as you may or may not know, is actually owned by some hospitals here in the state of Nebraska. So it's a provider-owned network, if you will, a lion's share. And they have partnered with some of the local hospitals here to create kind of like a particular network, Great Plains being part of this network. And so, you know, one of the recommendations is, hey, you know, maybe we could move to a program like that, and the underlying network discount would be Midlands Choice. And so that's why I'm benching against Midlands, because especially here in western Nebraska and just Nebraska generally speaking, out of all the networks that exist, United, Cigna, Aetna, Midlands, especially as you travel east, Aetna is in a particularly dominant position because of their acquisition of Coventry. So I think that Aetna is probably the best choice from that perspective. But now getting to what the mayor's driving at, and I completely agree with him, is our big concern is here in North Platte, what is the net effect of what we're paying for, and what's going to be the best vehicle, really to the point that the mayor's making, is to make sure that the provider's getting paid and the member's getting a good discount, and that we're cutting out as much of the middleman as we possibly can. And I guess what I would say right now, the data is telling me that Aetna would be in a better position, but what I hear the mayor saying is that there's going to be a difference between the net paid and is Midlands in a better position of overall net paid. At least from what I've seen, I don't think that to be true, but I want to verify. Did I misstate anything there?
No, I don't think so, and I'm not particularly cared about Midlands, Aetna, anybody. They all use the same mechanism to make money. I'm just curious about what the actual percentages are, because that gives us something to actually make a real decision about. So do we think this is fair, or do we not?
Now, one thing, and you know, with Tanner here, you know, one thing that and Ryan, I mean, we have a lot of professionals in this room who spent a lot of years in this industry. One thing that I will tell you that's going to be frustrating is that everybody's going to say, if you're going to drill down to a point that every single network is going to say that's proprietary and confidential. because they're not going to release their network agreement. So I'm gonna drill down to a point, and then I'm gonna hit a dead end because nobody's gonna release that information now. That being said, I think one thing that's going to be beautiful that's coming about, especially with the transparency laws, is everybody's going to have to start opening their doors and showing their network contracts. And that's going to be, I think, daylight is going to be such a great thing for the health insurance industry. And I think where we would probably all agree in this room is that it is the dark rooms of United Healthcare and Aetna that our healthcare costs have really exploded in this country because there's a lot of these deals. Now, really quick, what I want to show you, and again, this is just another thing. Philosophically, we've talked about, Ty, as we talked about, philosophically, it comes down to how we want to look at things. I will just tell you one area that we are pushing heavily into in terms of data is I guess I'm tired of percentage off discounts because it doesn't tell the entire story. And I would rather get to a spot of, I'm not advocating for reference-based pricing, but what I am advocating for is where can we have a benchmark that we could all say, okay, you're paying X percent here, I'm paying here, and we can actually know and say, okay, this is the best position to be in. And right now, a percentage of Medicare is a good barometer in terms of what are you paying and what am I paying. If Medicare is 100% and the city of North Platte is paying 200% of Medicare, that gives us a barometer of where they're at. Midland's Choice, they're at 190% of Medicare. They're at 210% of Medicare. It would actually be able to give us an opportunity to say, this is going to save the city money, this is not going to save the city money. And with all of that data that's coming out, our platform, we are actually prepared to ingest that data so where we can actually know as a percentage of Medicare what is being paid by Aetna, what would be paid for by Midland. So whether or not I can get to your answer, Mayor, that you're asking, which is a good one, I may hit a brick wall, but in the very near future, because of the transparency laws that have just went into effect, I may be able to get to a point where I can say, I know without a shadow of a doubt that such network is the best position for the city to be in.
Well, that's good. And if you can come up with some examples, just get a CPT code so we make sure we're speaking apples to apples as we look at it.
Well, and maybe it might be worthwhile. I mean, I always want to make sure we're doing everything, but I think you would enjoy as we go through this. I mean, even now, I can already dive into the city's data, CPT code by CPT code. So just, for example, again, this is all City of North Platte data. I can go into, let me just go abdominal pain. You had 14 claims, 8 different participants. You paid $21,000. I can actually come in here already, see where the provider was, and what the percentage of Medicare that was ultimately paid for that procedure. So we're getting pretty close to it already. But like I said, these network contracts have been so tightly held by everybody that when the daylight comes, I think it'll be absolutely amazing.
Yeah, it should be very interesting. There's no question.
Yeah.
There's a reason that when, you guys may not have noticed this, but when the Obamacare laws went into place years ago, insurance companies were limited at a 20% profit at that point. Imagine what businesses would love to have a 20% profit every year. And they were limited at a 20% profit.
Mayor, if I may actually, so the mayor's referencing what's called the medical loss ratio. And so what's interesting to me, and again, what I want you to take away from this is I'm a self-funded guy, and this is one of the reasons why I think self-funding is bar none the best avenue for most employers is, so it capped 80-20. 80% of any fully insured carrier's claims had to go towards paying claims. 20% was their cap. So let me just pause for a second. If you have $1 million in overall premium, so $800,000 has to go towards claims, $200,000 could be pocketed by said fully insured carrier. If you want to make more money, how do you make more money in that type of a world? You have to increase the claims bucket. And the beautiful thing about being self-funded is because you don't, in theory, have an insurance company, the MLR doesn't exist on the self-insured side. So again, there's an incentive to push claims down. But I think that's an excellent point.
Okay, I'm done asking questions.
All good questions. So just as a recap, and I know, Brad, I know you had asked about the comparison also to Ty's point. I will provide that. There was some conversation, Donna and Ty, about potentially a second plan design, potentially an HSA, HDHP, something we can totally look at. And then, Mr. Mayor, I know you had said, pharmacy spend and looking at potentially spread pricing. I don't want to misspeak on this, but again, the city is on a transparent pass-through contract, so there should be no spread pricing that exists in your program. But I want to verify that. And then the question that I'm hoping that I can get to, but that I think, like I said, it'll be interesting is that discount that we're arriving at. Because if the Midlands Choice, and I want to reiterate this, if Midlands Choice is the best network to be on for the city in terms of getting overall best net paid, let's do it. And I think what the mayor is asking is, again, how are we getting to that number, and are we comparing truly an apples to apples comparison in terms of what is being paid at the end of the day? So, everybody love health insurance after this? Everybody, everybody feel good?
I do have one quick question before we wrap up.
Please.
Promise to be quick. I was in the pizza line, I heard out of my ear that, did you say that the care coordinators aren't medical professionals, or did I mishear that?
Oh, no. The care coordinators, they are filled with pods of medical professionals. You
Medical
actually,
professionals. What level of licensure are they at?
so you have, within the pod, you have nurse case managers, you have psychologists, you have clinicians, and you have within Quantum, you also have MDs.
So I misheard that. I wanted to clarify
I'm
that.
actually really happy you asked that question. The whole point, just really quick, the whole point to Quantum is that you're accessing professional advice.
And Brad, I think since we're talking about health insurance, you meant the salad line, right?
Oh, yeah,
Rather than
the
the
salad
pizza
line. The salad line was delicious, by the way.
I did just want you to know and make a fair warning that because I saw the pizza, your rates are actually need to go up about 2%. So I can't unsee it, so anyways.
Okay, before we end up in jail, we should probably. Anyone else have any questions? Comments?
I just admire your knowledge of all that. It just blows my mind. I mean, I like numbers, but
I appreciate that. No, actually, and he has been largely quiet. I should say this just real quick. Ryan, who has been largely quiet, has been my mentor through coming up in this industry. And it's been, as most people were running away from it, I was hired right during the advent of the Affordable Care Act. And I will just tell you very quickly, my very first day on the job, I sat through a webinar talking about the Affordable Care Act. And I remember walking away, I think I called my wife and I said, everybody was speaking English, but there was not a single word that I understood. And I think Jan was probably giving us the training. And so, Jan, I apologize. That was, for me, I didn't hear anything. Anyways, I appreciate your time. Thank you.
Mayor, can I just make one final comment?
Go ahead.
I still wrangle with this, and I know we've already talked about it, but I've got 3 years left on my current city council term, and one thing that I really want to see, whatever we have to do this, let's roll up our sleeves and do it. I don't want to wake up in the middle of the night and have a choice between saving the taxpayers money and pushing our city employees to go get their services somewhere else. And that's, to you guys' credit, and I thank you for what you've done with our trend line and the help and the consultation you provide our city. It's nice where everybody else is going up. It's nice to see where our trend lines are at. But I hate having to make that decision. I don't feel like we should have to make that decision every year of do we push people outside of our community even if they don't want to, because it ultimately saves our plan money. We've got to fix that. And so my charge to you guys, just speaking for myself, not the entire council, but my charge to you guys is to help us fix that, because I see it as a very important decision. For our community, we need the economic development of being the healthcare center of western Nebraska, but we also need to keep our costs low. So we've got to figure out a way to solve this, because I don't think it's fair for us to have to sit up here and make the decision between those two choices. We've got to find a happy medium. So,
Ty, I accept that charge. Yeah, that's something I think I agree with you.
Anything else? Meeting adjourned. Thank you, everyone. Have a great day.